Welcome, everybody. We are in week 4 of our rural onboarding, very exciting. And we've been moving more into the surgical side of it. On Monday night, we had a great presentation from Dr. Hendricks looking at fractures, and he talked a little bit about conscious sedation there. But now we're really moving more and more in depth into the world of anesthesia. And we are very pleased to have the perfect person here tonight to give us some orientation on that. And Prof Dave Bishop is actually a specialist anesthesiologist who's working as a district clinical specialist. So these are these amazing DCST teams that are district based and are specifically orientated towards helping with fields like anesthetics within our rural health districts. So Prof Bishop is also an associate professor at the University of KwaZulu-Natal, and his main research interests are obstetric anesthesia, burns anesthesia, and peri-operative outcomes in resource-limited settings. He is an NCCEMD provincial assessor and is the immediate past president of OASIS, which is the Obstetric Anaesthesia Special Interest Society. His doctoral thesis, which was attained in 2018, was focused on pragmatic approaches to obstetric spinal hypotension in a resource-limited setting. And he's currently working on district anesthesia and education through an online program on a monthly basis. And he'll tell us a little bit more about that. And we will be sending you some information on how to link into that if you were interested in having some regular support on your anesthetic side. So Prof Bishop, thank you very much. We welcome you here from KZN, and I'm going to hand over to you now.
Oh, thanks very much. Thanks for having me here. I'll just share my screen quickly. If I can just get to my slides.
Yeah, I can see them beautifully.
Okay, let me just, for some reason, I haven't got the other aspect. That's what I'm looking for. All right, great. Thanks very much for having me here tonight. I'm always delighted to find people that are interested in improving their anesthetic skills. And I've got a particular interest in anesthesia in resource-limited settings. This is where I work. This is what used to be Edendale Hospital. It's now called the Harry Gwala Hospital. But I have got a background in district anesthesia. I worked at Mseleni, this is in KwaZulu-Natal, and that is Zituleli. I was in the helicopter for that picture. And those are the two district hospitals I've mainly worked with. But since leaving those hospitals, I've stayed involved. And I'm very interested in how you get safe anesthesia done in these settings, which I think is not always easy. It's my cell phone and my email address, which I'll put up at the end again. And as we go along, I really would encourage you to use them if you need them. I'm available for queries, whether they're on email or on the phone if my phone's on. And I'm very keen to hear about any issues or successes that you're having. Now, in a district hospital, you are required to get the Bellwether procedures done. That's really the standard of how we measure a district hospital's surgical service. In medieval times, you would put a bell around a castrated ram's neck, and he was called the wether, and then he'd lead the flock, and you could find them in the mist. And basically, a Bellwether procedure is something that leads or indicates a trend. And so district hospitals are expected to do an emergency Caesar, which is a general anesthetic or a spinal anesthetic, an emergency laparotomy, and the two that I always consider are an appendix and a ectopic pregnancy, and then open long bone fracture, a general anesthetic or spinal for that procedure, for the washout at least. And so that's really what we're pitching at. That's what you need to be able to do safely in South Africa. And your service is really structured around these things. I know that you end up doing pediatric burns and all sorts of other things, but this is really what a district hospital should pitch at. And one of the problems is that we're getting less and less good at achieving this. So in KZN, if you look at who's doing those procedures, you'll see that the district hospitals are not doing laparotomies and open reductions. And a big part of that, we believe, is that cesarean sections are now done much more safely under spinal. And so we're not routinely doing general anesthesia for cesarean section. And as a result, we are losing the GA skill. And increasingly, I'm finding district hospital doctors saying they are fine with spinals, but they can't do general anesthetics. And so really, that's the level we've got to get at least back to before we layer another level on. Now, in South Africa, in 2017 to 2019, there were 921 maternal deaths. So that's over a 3-year period. 7% of them were direct anesthetic deaths if they had a Caesar. But another 139 were indirect. And indirect means that the anesthetic contributed to the death. So the death was due to something like bleeding or an obstetric cause, but 15% of them, the anesthetic contributed in either inactivity or activity on the behalf of the anesthetist contributed to that death. So 1 in 5 deaths have an anesthetic contribution in South Africa, which is obviously way, way too high. And it's an area we need to do better at. Just one more on how we're doing. This is a study that we did from the ASOS studies. And we basically showed that peripotent complications in Africa around the surgical population, so the cesarean section complications, were 3 times higher than you'll find in the UK or the US. But our mortality is 50 times higher. And what that means is that when our patients complicate, they're complicating 3 times more, but we're failing to rescue 17 times more. We are much, much worse at handling those complications. And that makes sense. You can handle a Caesar when it's all going well, but when things go wrong or we're handling a complicated Caesar, that's where we are not reaching the bar. And so those sorts of things, we've got to aim at reducing complications. And when the complications occur, we've got to do better with those complications. And so that really is the focus of what I'm going to talk about tonight. I'm going to skim the surface a little bit because I can't cover the whole of anesthesia in this time frame. So I'm going to look at 3 sort of 15-minute sections. And then if there are any questions, I'm happy to take them at the end. The first I'm going to look at is systems, supports, and principles that you can use in a district hospital setting with your service. Then I'm going to look at some spinal tips and some GA tips. And I'm going to run over those quite briefly. The fuller talks are available online. I'll give you links to. And the obvious gap here is the procedural sedation, but there's only so much I can cover. And if I start getting into too much, I think we're going to miss the wood for the trees. So one of the first things that I'd like you to encourage to be in a district setting is to be intentional. These services don't just happen, they really need to be thought about. And so the first thing that I would suggest you do at a district level is pick a person to upskill. Get someone who's going to be your anesthetic lead. And often that goes hand in hand with if you've got a ventilator where you hold people over for transfer, they tend to be that sort of person. And district hospitals work like this. We've always got someone who's good at peds and someone who's good at medicine. And you need to choose someone who's going to be good at anesthesia or is prepared to develop an interest. And if you want to know how I recognize them, there's 2 types. The one is the one that when they hear something's going on in theatre, they find reasons to go to theatre. That person, that's who you want. The other way, it's slightly more subtle. The way that I recognize them is they have moon bags. And often they've got lots of different color highlighters in their moon bags. So organized people like that. You know them from med school, very, very tidy people. That's another person that you want to maybe choose to take over the anesthetic service. Either one of them. And once you've got that person, get that person to take ownership, give them time to organize theatre. Someone needs to be looking at the service. If you're all sort of doing it in parts, it doesn't really work. One person needs to take ownership of that service. And ideally, that's a bit of a long-termer. We often give our anesthesia to the comm service or the more junior people, but somebody needs to have that sense of oversight. And you upskill that person as well. And if you're going to send someone on inReach, send them to a regional hospital to get upskilled, then they come back and they share that knowledge and they cascade that knowledge down. And that's what I think works in district hospitals. In KwaZulu-Natal, we've got a circular that now says you have to appoint an anesthetic lead. And that person is the person I'm communicating with when I teach. And I think it's a good model, but I'll be very happy to hear feedback if you think something else works better. And just so you know, I'm giving these talks. This is the list for this year. I've done the first 3, started in November. And I run through a variety of topics once a month. And those topics, I have them on the 2nd Tuesday of every month. I send out the dates a little bit in advance. They're 45 minutes, but I stay online and answer questions February to November. And the idea is that we're going to look at an overview of anesthesia. and then get into the specifics once that overview is in place. So I'll do obstetric GA, and then one of them I will do just the airway from induction to on a ventilator, just that period, and sort of expand on that. And today I'm going to give you a bit of an overview of those first three topics that I've mentioned. And then I put them on a YouTube channel called District Anaesthesia Education. If you search for that on YouTube, it'll come up. And they are the talks that I've given, plus some other talks that Maritzburg has done. And these other talks are very useful. There's things like, how do you draw up your emergency drugs? How do you do a full anesthetic machine check? And you can literally watch it as you do it. How do you check the airway trolley, which is it's just a 5-minute video on what you need on an airway trolley. How to actually do practically a spinal. And these things are quite useful, I think, in you can watch them, refresh them 4 or 5 minutes, and you've got them done. My talks are, I'm afraid, are a bit longer. You certainly don't have to watch them, but if you miss the one that you're interested in, I just put them on there afterwards so you can go and catch up. And hopefully that'll develop into a resource. I'll pull other teachers in as well, so it's not just my voice. So you have to get to know your theatre, and there's no escaping that. In order to set up a system, your theatre must be organized. Now, fortunately, these are all what you need in that theatre has all been done for you. There's the ESMOE guidelines. We're busy updating these, but that is what you need in a theatre. And I would advise, I can send these out as well. I would advise that you laminate these and stick them on the wall so that you don't have to every single time think, what do we need in this theatre? This is what we consider to be the minimum that you should try and attain. Having said that, you can't possibly check this every time you walk in. So I want to give you a tip that I do in every single theatre I work in, whether I'm in a neonatal theatre, in a tertiary hospital, or I'm in a district hospital. I check 3 things that are there. I always check my ambu bag. Check that it works, and don't just see that it's there. Put your hand over the end of that mask and see that you can generate a pressure. Because when your ventilator fails, if you don't have an ambu bag in the room, you're going to be blowing into that tube, which I've done. So you really want a working ambu bag. Check it. It's a thing we forget. Check that you've got an oxygen source. In a district hospital, you're running off manifold cylinders usually. You don't have one of those big VIEs. But when that fails, it's very hard to fix. So check that the oxygen cylinder in the room is got some oxygen in it, and that there's a pipe that you can attach to your ambu bag. And finally, check that you've got a working suction. I cannot stress this enough. When you need suction and the suction is not working, there is nothing you can do. If the airway is full of aspiration, there's just nothing you can do. And so those 3 things, if they're all working, and with the suction comes tubing and a Yankau to actually use the suction. I trust the person who's looking after the theatre, and I check those 3 things between every single anesthetic that I do. And it's because I've been bitten on each one. So I really advise that you do that. Get to know your drug trolley, get organized, get your person with highlighters to put the drugs in categories. It can be the anesthetic nurse that does this, but someone needs to take ownership of it and stock it so that when you need things in an emergency, they're there. Just as a little aside, don't put tranexamic acid on your drug trolley, and certainly not on your spinal trolley. We're starting to use it more and more, and we had 3 incidences in 2 weeks this year, well, in the last few months, of tranexamic acid being given into the spinal space in a spinal, because the amp looks like and is the same size as bupivacaine. And people have been, that error is going up internationally. We've just written a warning for the Lancet. It's an international problem. So please try and store your tranexamic acid outside the theatre or in the drug cupboard. It's never one of those drugs you need in 10 seconds. You can always wait a few minutes. It's the drug you give whenever there's PPH in theatre, but you can wait for someone to walk outside and fetch it. So it's a new problem that we've got. And in terms of what drugs you need, these are the drugs you need, and this is how you dilute them. Again, it's a thing that I can send to you, and you literally laminate this and put this on your wall, or keep it somewhere, because you can't remember these doses. Don't try and remember doses in an emergency unless you're doing this every day. I don't think you can remember it. So cheat, just put it on the wall, and then you can just look at these things and find them there. Always draw up a vasopressor of some sort. This is a video that you can find at that website that I mentioned, which is the basic emergency drug to anesthetics, and they'll tell you how we draw them up. But I always have a vasopressor, whether that's ephedrine or phenylephrine, ready for a cesarean section. And then there's your airway trolley. And again, I'm not going to go through this now, but you need a working laryngoscope, ideally 2. You need different sizes endotracheal tubes, Bedell airways, and you need a supraglottic airway device. That's very important. An LMA or a ProSeal or an iGel, usually a size 3 at least. Check that that's there. And again, you can go and watch a 5-minute video on what we look for on the airway trolley. So it's worth checking out. And these are the things that you've got time to do before, but once you start, there's not really a way you can fix that on the time frame you have. And then machine check. Now, I know this is not something that everybody can do. Someone in your institution needs to be able to do a full one. It's worth knowing how to do. And there are 2 versions. There's the complete one, which you can find on that YouTube channel, and then there's the cheat one. This machine, I'll tell you the cheat one now, but this machine, if you look at it, there's no circuit. The soda lime is pink or purple. It's not on. There's no electricity. There's no vaporizers. There's no gas. And I'm just reminding you about that APL valve because you need to check that it's open when you start. What I do when I walk into a machine that I haven't checked and I've got no time to check it is that you must just occlude the end of the circuit. So put that mask over your hand and occlude it. Dial the APL valve, which I've circled there, dial it down to closed. Put the gas on and squeeze the bag and see that you can generate a pressure. And you're testing all sorts of things. You're testing that there's not a big leak. You're testing that you can give gas and you're going to be able to ventilate. And so that I do between every single anesthetic that I give. I always do it. And you'll see a lot of anesthetists do that just before we start. We put it against our hand, we check we can generate a pressure, and then we carry on. And it's the quick cheat to make sure that you've got the vital function, which is to deliver oxygen and ventilate. Anything else I can cope with. But if that's missing, the big leaks, for instance, and big leaks come when someone's changed your soda lime and you don't know, or the vaporizer is not seated, or you've got a disconnection. One of those pipes is off, and you want to pick that up before you put the patient to sleep. Okay, and then having done that, just some things about looking at your patient. Just a couple of principles that you really just need to be disciplined about. The first is just examine the patient. I think we forget this sometimes. Listen to the heart. Put your stethoscope on that heart and make sure you haven't missed a murmur. Look at the blood pressure and the heart rate and the breathing rate. The respiratory rate is a very good vital sign. And if they're breathing fast, it's a bad sign. Those patients are in trouble. And so just get used to looking at the simple things. I think sometimes we put patients to sleep and we put spinals in and we haven't checked for a murmur, or we haven't looked at the heart rate. And it's actually the simple things that we end up saying, I wish we'd seen that. Once you've done that, decide if the patient is stable or unstable. Just categorize them into those 2 things. If they're stable, they get one type of anesthetic. If they're unstable, they get another. And you have to get a feel for those patients, and I'll expand on that just now. And the reason is that if they're stable patients and you're anesthetizing me, I can have a whole amp of whatever induction agent you want. Amp of propofol, amp of etomidate, amp of ketamine. But if I'm sick, if I'm unstable, you need almost nothing. And so we call the ones that are a little bit unstable, that could probably have half an amp, and very unstable, a quarter of an amp. And I'll take you through those doses just now. But the principle is that unstable patients need hardly any drug. It's not the same recipe for every patient. And if you haven't thought about it, you'll just give you a normal dose. And the normal dose of propofol is lethal in an unstable patient. So just those little things before you start. And one of the tricks is there are all these tables that you'll find in ATLS about what someone's stable or concerning or unstable. But a quick one is the shock index. And all you have to do here is say, is the heart rate higher than the systolic blood pressure? If it is, stop and think. Heart rate's 110, systolic blood pressure is 100. That patient is giving you a warning sign. Whenever that heart rate's above the systolic blood pressure, just pause and say, wait, do we need to do something here? Do we need to give some fluid? Have we forgotten something? Or are we about to put a spinal into someone who is hypovolemic? So it's just a nice little pause. And we call that inversion of the shock index, when the heart rate goes higher than the systolic blood pressure. It's a good marker before anesthetics. It's a good marker during anesthetics. So in terms of preparation, know and prepare your theatre, prepare the theatre at the beginning of the week, not as you run in with your emergency. Examine your patient. And then finally, I know this seems obvious, but use your monitors. For some reason, when I went into the district hospital with my DA, I didn't put ECG leads on the patient, despite the fact that there was a working ECG machine. For some reason, I didn't use everything that was available. So if you've got capnometry, if you've got ECGs, if you've got a pulse ox and you've got a blood pressure cuff, put them on and use them. For some reason, we sometimes forget that. All right, so those are the basic principles. I'm going to run you through some spinal tips and then some GA tips. Now, I think spinals are actually something we do pretty well. District anaesthetists can do this. I'm going to just give you a couple of thoughts. Firstly, prepare as well as you can. I've been through that. Think before you put the spinal in. So just before you put it in, have a look at that heart rate. You shouldn't put a spinal into a high heart rate. And the rules that I've got for the regional hospital, now if the heart rate's below 100, carry on. If it's between 100 and 120, think, have you got a reason for this? Does the patient need some fluid? If it's over 120, but less than 140, a specialist must come and have a look, or a very senior person, and think. So when you're in the district hospital, you really want to be nervous over 120. And over 140, I never put a spinal into. I say that because I've reviewed lots of cases where they've been 160 and people have put a spinal in and then they're surprised that the patient arrests. Do the basics right. I'm going to come to that a little bit more. Expect common complications, which I'm going to touch on, and value the recovery period. So don't rush that period. A lot of problems occur in the recovery period. And finally, phone a friend, which I'll keep coming back to, but there's lots of times in an anesthetic where you can say, wait, we've got a bit of a time here. Things are currently stable. Get on the phone. And you want to cultivate friendships with your anaesthetists in your referral hospitals. And then outside of that, there are other people that will help you. So in terms of thinking, before you put in the spinal, why are we doing the Caesar? If the Caesar is for a cord prolapse, mother's probably fine. If the Caesar is for an abruptio placenta, are we right to put a spinal in here? So think about that indication. It often tells you what to do. What's the heart rate? And I've just been through those guidelines. If it's over 120, you'd better know what you're doing. So just use that as a guide. 120 is a marker for problems. It doesn't mean you can never put a spinal in, but you really must think. You know, if she's in pain and the blood pressure is high, might be all right. But if the heart rate's 125 and the systolic's 100, that's a worrying sign. So just look at those two things. And then trust your gut. Does the patient look sick? You often get a feeling. You just feel like the patient's not right. Stop and think. Get another pair of eyes on the patient if you can. And then are things likely to go wrong? Sometimes we take these patients who are grav 5, previous Caesar ×2, and they look well, and we carry on. But they're obviously at risk for bleeding, and we could have prepared for that bleeding better, or even referred the patient. So there's a little pause before you start, and just ask these questions. And finally, are there obvious contraindications, which hopefully we'll do in everyone. Now, the ESMO-E guidelines are out there. Again, I can send them to everyone. I just want to stress one or two things from them. There are guidelines to appropriate levels of care for anesthesia. And these things actually are quite useful. They were drawn up in about 2011. I wasn't involved in them. It was Dr. Farina and his team. And they've got a number of things that you should be able to do in a level 1 hospital and a level 2 hospitals. And one of the things they suggest is that we have a lead anaesthetist, that you should be able to do a GA and a spinal, that you should have a team of people, the right team of people in the room. And that generally means that if you're the anaesthetist, you can't also be the surgeon. And that's a big problem. About 7% of our maternal deaths, that's the case, where the anaesthetist has put the spinal in and then done the Caesar. We call that a solo Caesar. And I've done some of them, and I think we get away with them rather than they're not supposed to be done. And then remember appropriate referral. And I know, having been in a district hospital and talking to district doctors, that people throw their hands up when you say this, but it's worth knowing, because sometimes this does help us, that we've actually in the ESMO-E guidelines got the conditions that are required that you should be doing on site. And then we've got the conditions that should go to regionals and tertiary. And it's worth knowing, one of them, ruptured ectopic. Ask yourself where that should be done. That one needs to be done at district level. Unfortunately, you can't put a ruptured ectopic on an ambulance because the patient is unlikely to survive. So you have to set up for a ruptured ectopic. Very, very rare that we think the right thing to do is transfer a ruptured ectopic, just because of the hemodynamic instability. You can actually transfer a stable ectopic, but not an unstable one, paradoxically. If the BMI is over 40 or the weight's over 120, that is supposed to be referred to a regional hospital. And again, I know we can't get it done, but just be aware that that is in the guidelines for transfer, because those patients have just about every complication 2 to 3 times higher, and they should be in a regional hospital for that. And if you've assessed the airway as difficult, you can transfer that patient. And the problem with that is it requires that we're all doing airway assessments, and I'm not sure that we are. But a patient you don't think you can intubate is an indication for transfer, and you want to do that before you're required to manage that airway. I don't know an anesthetic department that won't accept a difficult airway, but you have to phone the anaesthetist before the obstetrician because it's an anesthetic referral. So just be aware of these things within these guidelines. And then these are the drugs that are required. Again, put them on your wall. There's a protocol for cesarean section under spinal anesthesia. And there's some very good tips in here. I don't want you to read that now, but I'm just going to run through a couple of the things that are important. The first is that you must think about the fluid stages before you start. Most Caesars are a little bit behind. So, but just assess when the patient comes in the door. You need a good drip. Good drip, we think, is ideally a 16 gauge, a gray, but an 18 gauge, a well-running green is okay. The pink is not really okay. You shouldn't be using a 20 gauge. So a green is the minimum. I suggest that we call this preloading, but it's actually rehydrating, that you run 500 mils of fluid in while you're getting ready for your spinal. Maybe not in your pre-eclamptics, but everyone else can use a little fluid because they tend to come in quite behind in fluids. They're not hypovolemic, they're dehydrated. Set your NRPP at 1 minute cycles until the baby's out. 40% face mask in all Caesars. This is for the mother. If you read up on this, you'll find the babies don't like the oxygen. There's a few more free radicals. But this is because if the mother needs to be intubated, you double the time to desaturation. So put 40% oxygen on. Co-load. So once the spinal's in, run 500 mils in fast with a pressure bag if you've got it. The spinal dose is 1.8 mils of hyperbaric bupivacaine. Even though you might have heard this, that you don't have to wedge, you must still wedge. And I just want to clarify one point. The wedge is important from the time you put the spinal in until the time the baby is out. But most of that time is from spinal in to skin incision. The skin incision to baby out, sometimes only 2 or 3 minutes. It's about 20 minutes from the spinal in to that point of skin incision. So wedge them and even tilt the table. You need 15 degrees minimum up to 30 degrees. If at the time of incision, it's causing the surgeon or whoever is your colleague that's doing the Caesar a problem, you can flatten the table for those 3 minutes. It's the 20 minutes that we are interested in for that wedge. Check your block. There's an article we've written that's coming out that I will distribute when it's published. It's imminently going to be in anesthesia. We don't check our blocks well enough, and I can do a whole talk on that. But it's worth checking that it's working before you start. Otherwise, you end up with a general anesthetic while the screen's up, which is difficult. The rules say if it's a failed block, so a completely failed block, no sign of it working at all. There's no leg weakness, no numbness anywhere. You can repeat the spinal between 20 and 30 minutes after your spinal. If it's a partial block, so you've got some signs of a working spinal, which suggests some of that Marcan went into the CSF, you must either wait 6 hours and try again, or you must convert to GA. Those are your two options. If you put a spinal into that partial block, the risk of a high spinal is very high. And finally, get your oxytocin dose right. That dose is 2.5 to 3 units as a bolus, plus 7 units into the fluid that you're running on the table. Don't give 10 units as a bolus. It can cause pulmonary edema. And then expect common complications. And this is from a study that we did at Edendale, now Hemorrhagic, and we looked at how often we get hypotension. And basically, half your patients will drop the systolic blood pressure below 100. a third of them below 90, and 20% of them will drop their systolic blood pressure below 80. 1 in 5 are going to get severe spinal hypotension, and it seems to be the elective patients that got more in that study. So you must expect spinal hypotension. It's going to happen. It's very difficult to overtreat this. So we know what happens when you put a spinal in. After a little bit of, once it's gone in, you tend to get a high heart rate and a low blood pressure, and that's almost across the board. That's from pharmacological vasodilation. So the treatment is vasoconstriction with a drug. So treat it aggressively. If you're not sure, give the drug. If the patient vomits, treat the blood pressure. If the patient becomes confused, treat the blood pressure. Just about everything, treat the blood pressure. So I give 50 to 100 marks of phenylephrine. If the heart rate's more than 60, I give ephedrine if it's below. If you don't have either one, just use the one you've got. I add fluids to it when the patient has got a low blood pressure, and then I look at cause. Before I even think of cause, I'm doing those two things. So all I really want to give you is, I want to urge you to treat that blood pressure early. 50% of anesthetic deaths in South Africa are from untreated spinal hypertension. Yet we know how to treat this. And if you look at these charts, when we review them, you just see the blood pressure getting lower and lower and lower and no action being taken. So get in there early. If you've diluted your drugs up properly, it's very difficult to cause harm. Even if you overshoot a little bit, it's not a problem. So drum this into people that they must treat this hypotension. Remember that not all hypotension is a high spinal. Most of it is not a high spinal. It's just severe spinal hypotension, and it's predictable. We've written this guideline for the management of high spinal anesthesia and obstetrics. It's a South African, it's contextualized. And just to remind you that the hallmarks of a high spinal are bradycardia, low heart rate, hypotension, and then some indication of a high block. And that's usually weakness of the hands initially, or the patient says they're having trouble breathing or loss of consciousness. That slow heart rate with a low blood pressure, that is very indicative of, and the treatment is ephedrine, or if the patient's an extremis, it's adrenaline and fluids. And that guideline really just looks at the pattern recognition and the treatment in a South African context. Now, as I come to the end of the spinal section, I want to just mention that what we're teaching for obstetric spinal anesthetics depends on the location you're in. So we call this context-sensitive management. So if I'm working here, the South African equivalent would be Gray's Hospital, although it's not quite as clean as this slide. I would tell you to individualize your treatment. Every patient gets a different recipe. I would not preload, I would co-load, and I would give them 20 mils per kilogram with a pressure bag. I would, to be honest, put a slightly higher spinal dose in, and I might even use an epidural. And I would run a titrated phenylephrine infusion in every single patient, 25 to 50 marks per minute, and I would titrate that. If I went to Edendale Hospital, where I've got junior medical officers, I would give them all some rehydration and co-load. I would use a fixed spinal dose of 1.8 mils plus 0.2 of fentanyl, and I would run a fixed rate phenylephrine infusion in every single patient at 25 marks per minute, and I would bolus on top of that. And that's my Edendale recipe, and that's published in ANA. And if I was in a district hospital, and this is what I do when I'm in a district hospital, I give everybody a bit of rehydration. I give them 500 mils as a co-load. I put a fixed dose of spinal in, which is 1.8 plus 0.2. And I take 500 marks of phenylephrine and I put it into that first liter that's running as a co-load. Once the spinal's in, I lay the patient down, I wedge them, and I open up that drip and I run a drip that's got phenylephrine in it. I'm only using that for the spinal hypotension, and I do it in all my patients. What I don't do is when the patient starts bleeding, is I don't use phenylephrine in that setting. In that setting, then you must use ephedrine or adrenaline. It's purely for the spinal hypotension. And I do it in all of them because it frees me up to resuscitate the baby and do the other things that I know how to do. Now, we've written an article on how to do that, and I can share that with you, but just consider using phenylephrine a little bit more aggressively for the anesthetic hypotension, not for the other causes. And then finally, value the recovery period. This is the last bit on spinals before I go into GA. I just want to mention, you're going in there on a 40% oxygen mask often. They must be off that by the time they go to the ward. Monitor, make sure they're not bleeding and they're well analgesed, and they're supposed to get oxytocin 20 units over 8 hours. But don't rush this period, because so many times we see patients with high heart rates and low systolic blood pressures sent to the ward, and then 4 hours later they're arresting. So again, high heart rates and low systolic blood pressures, which makes a high shock index, take it very seriously and just pause and think, because it's often the last time we have to intervene before it becomes a peri-arrest scenario. Okay, so I'm going to move into district general anesthetic. And again, I'm just going to give some pointers, and if you want the detail, you can go to that YouTube site. It's a simple concept of GA. It really is. You prepare and position your patient. Once they're ready, you induce them, you intubate them, and you ventilate them. Then you maintain them, you keep them asleep with something, and at the end, you switch that off and wake them up. And the bit that I think everybody gets nervous about is this bit, where you put them to sleep, you intubate them, and you put them on a ventilator. That's the bit that scares people that are doing this occasionally. And so all I'm suggesting is that you find ways to practice what scares you. So when you have a GA and you know what you're doing, find someone in the hospital that doesn't and teach them. You can practice on mannequins. There are sim centers, there's InReach, there's Outreach. Find ways to do this. If you're doing resuscitations in the ward, make sure you intubate the patient as part of that resuscitation. Don't call it until you've intubated, because we need to find ways to intubate. And you can practice ventilation by just putting an extra bag on the end of your circuit and setting it. You can practice setting the ventilator. You don't want to learn that when the patient's attached to the ventilator. Now, we've written this article. This is me and Simon Leroux, who works with global surgery in Cape Town. The two of us wrote an article called Anesthesia for Ruptured Ectopic Pregnancy at district level. And I'm just going to run through what you'll find in that article. It would be a good thing for you to read it. It's a quick read. It's pitched hopefully at district level. But the problem is that in that last report that has been released, we've got our increasing deaths for ectopics. 80% of them die with hypovolemia from hemorrhagic shock, and only 38% got an anesthetic, which means almost 2/3 of these patients are not getting anesthetized. And that is just means we're not giving them definitive management. The errors we're making, we're diagnosing them late, and then we're not treating them properly with urgent on-site surgery. That's the only treatment, so we have to give it. And then we're under-treating shock. And shock is initially hemorrhagic or hypovolemic, but it becomes other things if it's there for a long time. So it becomes vasodilatory. The heart starts to fail, it becomes cardiogenic. So you end up, what started as just being hemorrhagic shock becomes what we call multi-component shock. But if you get in early and treat it early, it's actually fairly easy to manage. If you leave it too long, it becomes very difficult to manage. And even if they arrive alive at the hospital, often by that stage, we can't treat them. So we've suggested, get a big drip in and run a liter in quick. Aim for a heart rate over 90, sorry, a heart rate under 120 and a systolic over 90. But don't aim for a systolic blood pressure of 120, because they'll just bleed more. Just clear the perfusing blood pressure, so 90, all you're aiming for. If you give a liter of ringers and you don't get them, give another one, or give half a liter of Voluven, or whatever your colloid is. So get 2 bags of fluid in quickly. Keep doing ward HBs if you've got a ward HB, a hemoglobinometer, because that HB is dropping as you're giving the fluid, as you dilute them. And aim for a hemoglobin of more than 7. If the hemoglobin is less than 5, I say you've got to give blood whenever. If it's between 5 and 7, take your blood to theatre and give it in theatre once you've got hemostasis. And if you give 2 liters, 2 bags of fluid, and you haven't reached those targets, you've got to consider adrenaline. This is a thing that's considered very late often. You've got to think about getting adrenaline in. There's 2 ways to do it in a district hospital if you don't have a syringe driver. The one is to put 4 amps in 200 mils and run it through a separate line, and you want to start that at about 10 mils an hour. So you run it through a rate minder or an IVAC or one of those dialer flows. If you've got a 60 dropper, you can use that. Just titrate to effect. The other way is just to put an amp into a liter, and you just run that on one line, and you just titrate to blood pressure. And either one of those is acceptable. Remember, this is an emergency, and we're just trying to get control. And then in this article, we've got this algorithm that we've drawn up that we're hoping can be laminated and stuck on a wall. And it looks complicated, but really it's just a reminder to go through these steps when you are about to put a patient to sleep. You oxygenate them, induce, paralyze, intubate, maintain, give analgesia, and extubate. And it reminds you that you must keep going with your fluid resus, check ward HBs, put monitors on. These are all, if you've got a forced air warmer, bear hugger, use it. But then what we hope that people will use is there's basically a recipe for each phase. So the induction phase says choose an induction agent, ketamine, etomidate, or propofol. If you're not sure, I would suggest you use ketamine because the propofol is not for unstable patients. So take ketamine 2 milligrams per kilogram, add a muscle relaxant, and I would suggest you use succinylcholine because it's quick onset and quick offset, 1 milligram per kilogram, and then intubate and ventilate. And that's the sizes and the ventilatory settings. And remember, the goal is oxygenation, not intubation. So if you can't intubate, just put an iGel or an LMA or a ProSeal in. It's acceptable to do an ectopic pregnancy laparotomy with that if you couldn't intubate. Just ventilate the patient and get the oxygen in. The be-all and end-all is not the endotracheal tube. Once you are ventilating the patient, you keep them asleep either by turning the gas on, and you start very low with like 0.3 of isoflurane, or you can just bolus them with ketamine, milligram per kilogram whenever they need it. And the recipes are there. Give analgesia and start with fentanyl, 50 mics every 30 minutes. It's written there so you can just read it off the wall and do that until they're stable. Only save your morphine for once they're stable. And remember that you've got a resus going on. So keep treating the hypotension with fluid and blood and ephedrine and eventually adrenaline. But most of these patients have got low blood pressures because they haven't had enough fluid. Treat movement, which we put there. And then just remember when you're going to wake the patient up, they must be hemodynamically stable. They must be not on adrenaline. They must be oxygenating. The HP must be more than 6. You want their temperatures more than 35. Reverse them if you've given a muscle relaxant. And the point I want to make here is that this is a point where you could phone someone. If you're not sure, phone someone. If you have an arterial blood gas, take one. This is a point just before you extubate. The complication rate at intubation is 4%. At extubation, it's 12%. We have 3 times complication rate on taking the tube out than we do putting it in. And if you think about when you take those tubes out, how many people are in the room versus when you put them in? Whenever I put a tube in, there's 10 people in the room. Whenever I take it out, it feels like it's just me and somebody mopping the floor. So it's a high risk time. So just pause and think through it and make sure the patient is wide awake. The more alone you are, the more awake that patient must be. And then remember again, the recovery period. Get them wide awake. Make sure their heart rates are down, the systolics are up, they're not actively bleeding, and they're not in pain. And again, you can phone them. So the recipe for that is for the topic is very simple. It's induce with ketamine and sucks, maintain with a bit of isoflurane, and at the end, switch it off and take the tube out. That's how simple it can be. But those things are only simple if we're doing them often and we've thought through it from the beginning. I've thrown a lot of information at you, so I'm going to finish with some stuff on an obstetric GA, but only the points that are different. And then I'm going to just consider that our brains are full and I'll take some questions. Again, before you put the patient to sleep, think, why are we doing the GA? And am I prepared for what could go wrong? What's the heart rate? What's the systolic blood pressure? Do I feel like this patient is sick? And if the patient's sick, I know that there's not specialists in district hospitals, but there's often another pair of hands. Get your hands in at that point. Just have a couple of people in the room and then they can go back to OPD or the wards. Have you looked at the airway? And get into the habit of assessing an airway. I don't mind if you get it wrong, but the habit must be there. And then as you get the habit in, we can start to break down the 3 areas that you must look at in every airway, which is, can you mask ventilate? Can you intubate? Can you do a surgical airway if you need it? It's in the ESMOE guidelines. This will be the topic. I'll give this as another talk when I talk about airways in a district setting, and I'll break it down how you evaluate an airway. But just try and do it in every patient, because then the habit will be there and the skill set we add later. And then this is 4 things that I would like you to consider in every single obstetric GA that you give. I'm going to put a lecture on this that's going to be given by John Mark Tomlinson at SASA, and I'm going to put it on the YouTube site probably in about 2 weeks' time. But there's 4 specific things to consider. The first is ramp the obstetric patient. And by that, I mean, if you can, wind the head of the bed up to about 25 degrees. You can do it either with a handle or you can put a wedge in. What this does is it takes the weight off the lungs and it increases the functional residual capacity, and it works. And it's easy to do, and you can intubate in that setting. Don't put them into a position where you can't intubate, but just ramp them 25 degrees. Pre-oxygenate, and I've said ×2, so don't skimp on this, 3 to 5 minutes of 100% oxygen. And what we're starting to recommend is that you also put a nasal prong around the patient underneath that. So put the nasal prong on, turn that to 5 liters, and then put the mask on. And you leave that nasal prong running until the patient's intubated. And what happens is then when you take the mask off, that nasal prong oxygen keeps giving oxygen while you are faffing around with the laryngoscope and getting everything ready. It's just doing something we call apneic insufflation, and it prolongs the time to desaturation. In a regional hospital, 1 in 6 patients drops their sats below 90%. That's with experienced anaesthetists who've got diplomas. So, yeah, and that's true even in Curtis Care, their incidence is 13%. So in a district hospital where you are an occasional anaesthetist and you won't be as fast just because it's a habit that you haven't learned, they're going to desaturate. So do double oxygenation. It's easy to do and the equipment's not hard to find. Gentilate. I'm going to show you on the next slide the algorithm, but essentially what this means is that once you've given your induction agent in your sucks, you keep the mask on and you ventilate the patient at 15 to 20 centimeters pressure. So it's not a true rapid sequence. This is in the guidelines. I didn't come up with it. It's in the UK guidelines. Low pressure ventilation while you're waiting to put that tube in. So you've got that 30 seconds while you're waiting for your sucks, just ventilate them. If you can't, don't worry, just intubate. But it does a lot of good things and it takes all the rush out of the obstetric airway. As long as you don't go over 20 centimeters of water, you don't have to worry about aspiration. It's not a risk. And if you can't intubate, just put a supraglottic airway device in. It's not a failure. The goal is ventilation and oxygenation, not intubation. So 2 attempts, put your supraglottic airway device in. Don't keep trying, because as you keep trying, you make the tissues edematous and then you can't mask ventilate anymore. So you have a couple of goes and put that supraglottic airway device in. And the number of cases we've had where it was never attempted. So it's a reflex you've got to generate. I've done this when I can't intubate. You just put a supraglottic airway device in, you finish the Caesar, no worries. Look at positioning before you put them to sleep. If you have to reposition because you can't tube, then you didn't get the positioning right at the beginning. This is not appropriate. This is. So get that head up into the morning sniff position, that ear in line with the sternal notch. Look how that patient's been ramped. It's towels, it's pillows. Get the head nicely up. And as you can see, that thyromental distance is now nice and long. Guarantee you this is a grade 1 airway. The one before that, you're going to struggle. So position the patient before you start. And this is the Difficult Airway Society guideline for how you do an obstetric GA. And I just want to remind you that you should consider face mask ventilation, that's gentilation. And you should actually do this in every patient. And you put in a supraglottic airway device after a maximum of 2 attempts. If you don't want to do that, you can ventilate them, but don't keep trying. So we call it 2+1. You can have 2 attempts. If you've got some ninja of an intubator in your hospital, they can come and try once. But really, you just want to bail early and put your supraglottic airway device in. And if that all fails, then you've got to do surgical airways. And that's actually not something that I'm focusing on. I think that if you get to the supraglottic airway device and then you fail, you've done what we can expect you to do in that setting. And the goal is ventilation. There are failed airway drills in the ESME guidelines. I'm not going to run through them, but when you can't intubate, you will never remember this unless you've drilled it, because your recall is about 25% when you're panicking. And when the sats are dropping and you are panicking, you're not going to get through this. So what you need to remember is mask ventilating, supraglottic airway device and intubation. And after that, then I'm afraid it gets a little bit more hairy. But in most cases, you don't get to this. We haven't had a surgical airway in an obstetric patient for a long, long time. And finally, I just want to remind you, I keep saying this, that you can phone a friend and you can get help. You might be in one of those settings where you can't get access to help. Ideally, this is your regional hospital. You need to develop a relationship with them. They need to come and do outreach. You need to go into inreach. You've got to find some way to upskill. There's lots of resources online. We're starting to work on podcasts. There's videos you can watch every Tuesday. Like I said, every second Tuesday of the month between February and November. And if you don't have a friend, then I'll be your friend. Just send me emails. You can try me on the phone. I'm not as reliable on the phone, but if you send an email for "we had this situation and what should we have done," I'm very happy to break it down and go through it no matter what province you're from. You're welcome to try the phone number, but I can't guarantee that I'll answer it because I'm often juggling a few balls, including having 3 children. But I'm very happy to talk about events and go through them. If you're struggling with systems, we can work on that. If you need protocols, I've got tons, and I've got way too much literature on just about everything. So if you want a specific issue addressed, and then on those talks that I give, if you say, look, we want to know how to do procedural sedation for burns, we can go through that, and I'll do a whole talk on it rather than going over the whole subject like I have in what's now 50 minutes to try and cover the whole of anesthesia. So I'm going to stop there, and I'm very happy to take discussion or questions as we go.
Thank you very much. That was amazing. I think you have just saved a few lives in the future, and it quite often happens that once we want to attend a talk, and then the next week, usually something happens, and very, very important. And I would just like to see if anybody has any questions. You can either put them in the chat or you can unmute yourselves. Just to confirm, all of those resources that Prof Bishop has mentioned, I've added to your packs. They will either be in a Google folder for you to easily print and download, including those algorithms and some of those posters, as well as all the ESMO e-posters, as well as the link to his YouTube page and his contact details. I'm just seeing if there's any questions coming up. I'm going to launch the poll so long while people think. So the poll's also a good idea, a good way for us just to keep track in terms of who's attended. It looks like there's a question that's come up there.
Yes, is abruptio also considered too unstable to transfer? That's an excellent question. In general, a live baby abruptio needs to be done on site because you're trying to save the mother and the child. And a live baby abruptio is often more stable because you haven't reached a point where the baby has died. So I would say a live baby abruptio you've got to do on site. Can you transfer an abruptio to a regional hospital? That actually is going to come down to the discussion with the obstetricians. In general, you've got to get that abruptio out. So there are some that are concealed abruptios or that are more stable. It comes down to stability of the patient. The trouble is that they become increasingly coagulopathic, and sometimes you've actually got to proceed. But it's not one of those ones where I'm prepared to give a blanket rule that you have to do an abruptio on site. We did one this weekend where it was transferred in. It was an abruptio. I don't think I'd have asked those district hospital doctors to do it because there are limits to what you can do. The platelets were 26. But having said that, I think you've got to aim to do abruptios on site. You've got to be prepared to do them. And then that phone call to the obstetric or anaesthetic service at your regional hospital is often what you need to then make that final decision. I think you've got to try and do live baby abruptios on site. Placenta previous and placenta accretus spectrums, those ones you want to try and get out of there because the abruptio placenta surgically is usually fairly straightforward for beginner surgeon. I could do an abruptio. There's no way I could do a placenta accretus spectrum. So I think the placental abnormalities you've got to think about. And we didn't talk about PPH today, but the placental problems get coagulopathic early, whereas the trauma and the tone causes, they get coagulopathic late. So these are definitely difficult cases to do at regional level. Good job. So not a fixed answer, I'm afraid.
Also, in terms of, thank you very much, in terms of the more obstetric side of that, Prof, in the obstetric pack, Prof Justice Hofmeyer has got some excellent presentations specifically on postpartum hemorrhage and on complications in cesarean sections. So he covers some of the top tips and stuff that you can do while you're trying to get your patient to the appropriate place of care. So they'll be in your obstetric resource packs. I think there's another comment or question there in the chat.
Yes, let me just pull it up. I saw it was about, let me just get into that. So there was our hospital often doesn't have phenylephrine, only adrenaline. What do you suggest for rehydration and infusion during the Caesar? So firstly, just as the standard, I understand that this happens, but one must also realize that it's unacceptable to only have adrenaline. So your hospital needs to can have ephedrine. I don't know if they've got ephedrine and adrenaline and fluids, that's fine. Or some people have etylephrine or metaraminol. You need another vasopressor before adrenaline. If let's just say you're in this situation where you've only got fluids and adrenaline, we don't recommend running an adrenaline infusion prophylactically. So you've got to get your fluids bang on, so you've rehydrated and you're getting them appropriately. And then what we do is we draw up adrenaline and we put an adrenaline amp. Essentially, you make a 5 mic or 10 mic solution and you use those as boluses. And it's a situation that I'm uncomfortable with because there's absolutely no research. There's 1 or 2 hospitals in Brazil that are doing research on this. And essentially, it's a situation you shouldn't be getting into. Phenylephrine is fine, but if you've only got adrenaline, that's a problem. And there are certainly ways to do that. Personally, I would be giving the boluses of 5 to 10 mics as needed. And then I would be looking at putting a single amp in 200 mils and titrating to effect. But it's not got a lot of research behind it, and there are quite a lot of risks to running adrenaline infusion peripherally. For me, it's a thing that you do in extremis, not in elective situations. Don't see any more questions. I'm happy to.
Not seeing questions there. I think that's great. People need to also get back to life and
Sure. Absolutely.
And it's great to have this as a resource. So it's the kind of thing people can watch again, and that will obviously distribute to those people who didn't make it this evening. Prof Bishop, thank you very much. I think you've certainly grown your audience in terms of people who will be joining some of your future lectures. We look forward to those, and we look forward to supporting those. Yeah, and I think there's also a lot of work happening in surgery and trying to create a better basket of surgical care within rural facilities, and you can't do that without your anesthetics. So we would like patients to be able to access much more surgical procedures, even simple procedures, in district, instead of having to be referred to big regional centers. But one of the big barriers is anesthetics. If you can't do your anesthetics safely, or if your machines are not up to date, or you don't feel confident with your drugs, then you also can't do surgery. So absolutely key. Have a lovely evening.
Thank you.
I'm just going to ask you to please send me that updated list of the drug that you have. I've got the old ESMO-E drug list from 2011, but I see at Pietermaritzburg you've got an updated drug list.
Yeah.
If you could send me that, then I'll just add it to the pack. I've got all the resources you've mentioned.
Oh, well, we've got a sort of a 20-page document. We've got the ESMO-E guidelines, and we've kind of adjusted some things around it to make it easier. I'll send you that.
Okay, excellent. Please, that'll be amazing. Thank you very much. Thank you very much, everybody. This is then the official end of the meeting. And next week, we're going to move on to pediatrics. Our lecture is going to be on Monday night and Tuesday night, so a bit of a bumper week. And we're going to have Dr. Keert. We're going to specifically be focusing on the sick infants and the small sick child in terms of supporting those. Thank you very much.